It's much easier to destroy tooth structure than to conserve it. It takes more time, more patience, more skill to save it than to just rip it down. I think the first place to start is to add, and then you can always subtract later, but you have to look at like what's really best for the patient.
I know that you are referred to in your area by a lot of folks who just don't want to touch the kind of cases that you do every day. Hey everybody, welcome to the Dental Handoff. I'm Dr. Kelly Tanner, and today I have with me once again the Dr. Michael Morgan. Hey Michael, how's it going,
Hey.
my friend?
Hey Kelly, how you doing?
Good. I just saw you at the Gulf Coast meeting, and gosh, that's been a month ago. That's crazy.
Whole month, yeah, kind of crazy.
Yeah, it's the speaker world is fun. We get to see each other, and I think the coolest thing about speaking is that you get a lot of cool questions from the audience, and you get to learn a lot from other people too. Would you agree?
Oh, absolutely. Yeah, it was a really good meeting besides being in a really nice, warm place. Yeah, it was a great crowd. People were super friendly. I think it's part of that whole kind of like Alabama upbringing. They're all like laid back and very kind.
Very chill. Yeah. So it was at Gulf Coast, but it was the Alabama Dental Association meeting. So
Yeah.
everybody was just hospitable, and the location was a bit distracting to go outside and walk on the white sands. I was like, man, what have I been doing inside?
Yeah, it kind of blows attendance in your afternoon sessions. That's how mine was. Morning was packed, afternoon, the sun came out. People are like, I'm going to the beach.
Yeah, but then it thunderstorms, so hopefully they come back.
Yeah.
Well, I want to start by saying this episode is sponsored in part by Ivoclar, so thank you for their support. We will be talking about some of their products, but the reason why we did all this is because we're seeing some major upgrades in the types of materials that are being used, that, from the first generation types of materials. And Michael, I know that you are referred to in your area by a lot of folks who just don't want to touch the kind of cases that you do every day, almost not with your eyes closed, but um and I found it fascinating, and this is one of the reasons why I had you on, because of the images that you show during your presentations, and um, how you're using the materials as what I told him before we got on. I said, you're almost like the fine arts department, where everybody just goes, that's just too much work. Give it to Dr. Morgan.
Oh, yeah.
So
That's
tell
kind
us
of what
about,
happened.
how that comes about. How do people find you for those types of things?
Well, I think, I started lecturing about like 25 years ago. And at first I was doing more things local dental societies, midwinter, things like that. So my name kind of got around. I did the first webinar ever for Chicago Dental Society. So my name got around, and I found out that a lot of my colleagues, our colleagues, don't like composite because it's too labor intensive, requires a lot of training. Let's, if you just want to slap one shade on there, fine. That's not terribly complicated, but really good layering is really labor intensive. It's really artistic. It takes a lot of time to learn. And I spent a lot of time traveling different countries, different people, to learn from the people I thought were the best. And most of our colleagues don't want to do that. So especially now with the 3D world, I mean, 3D can do some really, really nice things, really good things, but it's not great. And then there's some cases, like one of the ones we'll talk about today, or actually two of them, that you just can't do with 3D because it's just not to that point. So yeah, I get referrals from some of the local docs. We just started a campaign like 6 months ago where I reached out personally to all the pedodontists and the orthodontists in the area. We put together a packet for them explaining like how we can make the pedodontist life easier and how we can make the orthodontist life easier, showing them examples. I've gone to the offices, I've trained some of them, and what they realize is, there's some really cool stuff out there that doesn't require us or anybody prepping a tooth, especially on like an 8-year-old. That's like a tragedy. And then, so they know enough to know, maybe do a little something in their office, but if it's complicated or they're not comfortable, then they send them to me. So life is all about win-win, but in this case, it's win-win-win, because the patient wins because they get great treatment. The referring dentist wins because they have a happy patient. And then I win because I get to do what I love. So everybody's happy.
That's brilliant. When you said that earlier, I was like, okay, I didn't think about that strategy, but you're right. I mean, those docs, they do, because I'm thinking back to my childhood. I saw a general dentist and I had hypocalcification basically on my maxillary anteriors, and he did his magic with the composites then, and I know it
Right.
took him forever, and I can't imagine what kind of material he was using, but to have that in a pedodontist office or an ortho practice, I think would be so helpful because they get to identify it early and they can manage it alongside of your help, and they can see certain conditions developing and then make those referrals early in case they need to consult with you about end treatment. So I can see how all of that would that's a great referral strategy. So
Yep.
that's brilliant.
And there are, like I said, there are just some of the GPs around here just don't enjoy. They want to prep because it's always easier. It's much easier to destroy to structure than to conserve it. It takes more time, more patience, more skill to save it than to just rip it down. So unfortunately, sometimes I see cases around here where young people, and I'm talking about young people between like 8 and let's say mid-teens, who they break off part of a central and then they go to a different practice and they prep it for a crown, which is like crazy because we have the technology and the knowledge to add to the tooth to give back, what they were born with rather than cutting more away. But the thing that happens is then when you do composite, you're both the doctor and the technician, both. And if you're not comfortable doing the technician part, then you're going to prep it or perhaps prep it and send it to a lab and let them do it. But the thing with lab work is it covers up all sorts of not great stuff. So you can have this wonderful porcelain, but you don't really know like what's underneath there.
Yeah,
Uh,
that's true.
yeah, and we get a fair amount of patients who come in for second opinions. My child has this going on. They have a pig lateral. They broke a tooth. They did this, and most of the time, and sometimes they show me the treatment plans. They're for indirect, so they're for porcelain veneers, crowns on very very young people, which I don't think is the first place to start. I think the first place to start is to add, and then you can always subtract later. So like even both my kids, my daughter broke a tooth when she was young. So for sure, I did a class for composite. And then when she was 18, like most young ladies, she wanted some veneers. So I did composite, all additive veneers on her. And then my son last year, I did composite, all additive veneers. So when they get older, if they decide they want porcelain, and composite does wear, if they decide they want porcelain, great. You can always do that. But if you prep them now, then you doom them to being prep for the rest of their life. And it's a little different. It's a different philosophy because I did some of my schooling in Switzerland, and in Europe, they're very conservative. They always add first, subtract second. And this country's kind of reversed. It's prep, cut, go fast, bigger production, bigger this. But you have to look at like what's really best for the patient.
Yeah, for sure. Yeah, I felt, knowing what I know now, I felt very grateful that my dentist was minimally invasive before it was even a
Yeah.
thing, because he could have done other things at that time. So what are, I know that we had mentioned some cases like in my case or a case that you're seeing with like hypocalcification.
Yeah.
How do you care for that type of patient, and how are you adding it to the tooth?
Well, you can, the challenge with hypocalcification is when you look at those spots, you don't know actually how deep they are. They could be like a tenth of a millimeter. They could be like the young lady we did yesterday. It was over 2 millimeters deep. So that's a big difference. So if you're going to do something like icon, some kind of resin infiltration, those need to be superficial spots. But there's no way to measure that. You take an x-ray isn't going to tell you anything. Transillumination, a little bit, but you don't really know. So I tell patients we can try this first because again, it's the most conservative, and it'll probably make some of the white spots smaller, but it's probably not going to make them all go away. So then if they have some of this to bother them, then I can do small direct composites. So with the young lady yesterday, when I look at the tooth and when I looked at it from the lingo, I could just tell this area of hypocalcification is all the way through. So there's no way icon's not going to do anything. So I ended up doing up a small direct composite, but because teeth are multichromatic, if you just slap on one shade, it just doesn't look real. It'll end up looking kind of like when you see what the decalcified area looks like, which is monochromatic. So it ended up being a dentin layer, an enamel layer, a little bit of white tint, and a little texturing to get it all to match in. And that's kind of, I talked about that down in Florida. Somebody asked me, they're like, what's your secret sauce? Secret sauce. Yeah, like what's your typical setup for a composite? I said, it's three things. It's a dentin layer, it's an enamel layer, and it's some white tint. That's like my secret sauce. It used to be 6, 8 shades of composite. That's crazy. That's like back when I was, totally insane. Because that heats up a lot of time. But now new resin technology, new, especially optical technology, a lot of these cases can be done with just 2 shades, and it doesn't take very long. And then white tint's the little thing that kind of jumps it from good to much better than good, which you'll see like both these cases have white tint, which is it's actually Ivoclar color, which is it's very easy to direct color. It's very easy to apply with a little brush. And yep.
That's cool. Do you have any that you could show us?
Sure. Let me start with that hypo case from yesterday. So we do, young lady, this right here, this area really bothers her a lot, and that's pretty normal. She's like 16 years old. So, all young people are very conscious of their appearance, especially young ladies. And she just got her braces off. So she has some diffuse hypocalcifications, which I told mom probably best treated first with like MI paste. And then if that doesn't go away, then Icon might be successful for her. But this lesion right here, there we go. I can blow it up. This
Brilliant.
This, yeah. How did I figure that out? Oh my God.
Oh, I feel like I'm in her mouth right now.
Yeah. Well, and that's the one.
Be that close.
So we have giant screen TVs in all my rooms, and they're not for watching movies. They're for putting these pictures up and blowing them up, so patients can see. Therefore, they can understand like what we're talking about. And also let me ask her, well, does this dark spot bother you? No. It's just this bothers me. Okay, that's good information. You don't want to treat this and then come back and she said, oh, how come you didn't do that? So anyway, this ended up being almost a through and through, meaning as I slowly went through this, I'm measuring with a caliper like how much room I have to like go out the lingual, and we're getting close enough that it's time to stop, and then just put an opaque dentin shade over this, and then a little bit of white tint, because if you look, well, and her teeth, they get dried out, they get decalcified while we're doing this. So that's one of the tricks. When you pick out a shade to do any composite, you have to stick with it, because as you work, the color of the teeth will change, which will make you think, oh, shoot, I picked the wrong color. No, you didn't. It's just things are going to change. And I told mom afterwards that this color will be a little bit off because it has to rehydrate. So dentin shade, a little bit of white tint, my favorite thing to play with, and then enamel shade over. And then if you look at, she doesn't have a lot of microanatomy, but she has some. So you can't just make this all flat and think it's going to look real. So what we do is, we try in different shades of composite. So this is actually Empress Direct composite. And so there's an enamel shade there. There's a dentin shade. Yeah, these are not IG worthy pictures because I didn't make this a perfect circle. There's a whiter shade that obviously I didn't like. There was one a little more towards B that I didn't like. So I picked these two. So this is the dentin. This is the enamel. I prepped it out. No, I didn't take a picture of the prep. Sorry. And so then this is after. So a little dehydrated, things are a little white, but that was right through here. So the dentin blocks out the remaining part of the hypercalcification, and then the white tint helps it blend in, so you don't just have this area that's kind of has a grayish translucent shade. And then you need to polish it so it looks like the other teeth. See, there's like little scratch marks here that she has on all teeth. So there's like several different instruments we use to do that. And then just little things that, us geeky dentists get into, like making sure there's these notches are the same size and stuff like that. That's really not, doesn't have relevance to the function, but it makes us all feel better.
Got to put her mamelons back.
Pardon me?
Got to put her mamelons back.
Yeah. So yeah, I'm pretty happy with this came out. And then you can see Optrogate up here. So when I got back from studying across the pond, I was a big rubber dam guy, and then I slid back to the American side. And a lot of American docs don't use anything, but I at least like the minimum Optrogate or Optrogate 2 to keep things. We have a bite block down here, sometimes a tongue sponge so the patient can't lick, and we get at it. So
Beautiful.
that was the one we did yesterday.
That's awesome. And then so it rehydrates. It looks, it has.
Yeah. So I'll have them back in a week, and it'll rehydrate. And if the color's off a little bit, it's easy to fix. Because the difficult part was the prepping and the dentin and the way the dentin's laid down and all those things. So if I had to change the surface color, that's not difficult at all.
That's awesome. Was she
Yep.
happy? That was life-changing for her, I'm sure.
She's a happy little camper. Yeah, I talked to Mom this morning. She said she's super happy. So
That's good.
I'm happy.
And then, thank you for sharing that. And then, thinking about too, with cases like, peg laterals, that how do you manage that through ortho on your end? Do you let them do the ortho first and then they come to you, or how does that usually work?
No, that's really dangerous. I want to see the patient as early as I can see them. So if that's initially when they're starting, that's the best, because what I do is, and we created I think I mentioned a referral sheet for orthodontists, and part of it says I do their space planning if they want me to. I'll take the whole upper arch and tell them if there's two size discrepancy, or they're missing a lateral, they have pig lateral, any of those things going on, I'll tell them what the ideal spaces would be for each tooth, and then try to guide them into getting the teeth to that position, so that when the patient's old enough, if they're going to have an implant, they're going to have an implant, or they may end up having, I do a lot of composite for pig laterals, but it's setting up the case so that you have symmetry, amongst all the teeth, and you don't have one huge lateral, one skinny lateral. But the earlier I can see them, the better. And then for sure, about 3 months before they're quote unquote supposed to be done, I want to see them, because usually there's something I want them to tweak. So the orthodontists aren't always happy with me, because they want the patient to be done, and I'm like, no, you need to, this needs to go another 0.5 millimeter. But that's up to them and the patient and the parent. And most of the time, when I show the parents some examples of how different the case could look from other people we've done, then they'll go back to the orthodontist and say, yeah, do that, do it. So sooner the better.
Okay, yeah, that's awesome. I always wondered how that was timed out with those peg lateral patients and at the orthodontist. I mean, it's kind of similar with the implant patients, I'm sure, and their dentist and the oral surgeon and ortho, just the whole thing. It's planning it all out and kind of working the timeline backwards to say, what does this look like? Is the patient aware? Are they going to be surprised that when they have to go back and forth and fine tune things a little bit? But usually at that point, it's either, I think it's usually one of two ways. They're usually ready to get the heck out of ortho and they're just done with it, or the clear aligners and they throw them across the room, or they're like, I've done this much. Let's do the final bit.
Yeah. Having a beautiful result is worth a little bit of time. It's just challenging sometimes, because as adults, we understand time, right? We understand how that's relative to when we're young, when we're a little less young, but young people are always like, I want it now. Everybody's used to getting their Amazon stuff today or tomorrow, and they want their teeth the same, but biology is just a wee bit different.
Yeah, for sure. So, you're using these products. Are there, did you have another case to share? I'm sorry, I didn't ask you.
It's okay. Is there one? I'm sorry.
Is there another case that you wanted to share?
Yeah.
Or is that
Yeah, we were talking about, let me show. So this is an article that got published last month in Compendium. It's called My Finest Case. They asked certain doctors to send in certain things. So they asked me if they could print this. So it's a case where a young man broke his front tooth. So this young person went to a local pediatric practice because they had an emergency on the Saturday. I work Monday through Thursday. I'm jack of all trades, but non-clinical on Friday. So this is Saturday, right? And emergencies don't wait for us on Mondays. So the young pedodontist, female pedodontist, like patched us up the best she could. She did a nice job, got the patient out of pain. But then they called over here on Monday. They're like, hey, Dr. Morgan, can you take a look at this? And I said, sure. So we brought this person in, and they already, the reason I transition all photos start and end to black and white is to look at value. So this tooth, the one that was injured, is already getting darker because you can see the value difference, and we haven't even started treatment. So this is a case, I do most of my cases now digital. So normally I do all my cases digital, but there's times that analog is still helpful. And this is one of them. So I actually waxed this up on the stone model to recreate what was gone. And you can see when I did that, it's not just the incisor we see, but actually somehow part of the facial got broken off too. So this is the prep. This is, of course, everybody's favorite etching. This is adhesive. There's metalingual stent, set of proximal. These are called M bands. They're from Garrison. And then remember I said 2 shades, so dentin shade. Well, there's enamel on the lingual, dentin, and then enamel on the facial. And then I went through the polishing sequence and got this one to look just like the next door neighbor. And then at the end, same thing. I made a no bucket. See, this tooth is darker than this one. So the parents have been informed that we have to keep an eye on that in terms of possible endodontic issues in the future. So as I mentioned earlier, I mean, 3D is great. And I've seen some docs online where they'll take this same situation and just 3D print a piece and bond it on there. I think that's acceptable, but you're not going to have aesthetics like this. You just won't, because this is different layers with different optical properties. So I still have a mix in my practice. I do both. Honestly, I still get a kick out of doing this, the layered, but it's much more labor intensive. But this is also where, you know, certain products come in, like for curing, we use blue phase light. Not in this instance, but in other ones, it has this little 2 millimeter tip that I love. So we tack veneers, tack crowns. In a situation like this, we don't use it. We're actually using, you know, the full tacking or curing tip. And then these were, let's see if I showed it. No, I didn't show it. These were polished with Optogloss. So my sequences, discs, then enhanced to make, you can see the mamelons, and then you take red articulating paper and run it across the front so you can see the anatomy, do some tweaks, and then Optogloss polish, and boom, it's nice and shiny.
That's beautiful. Beautiful, beautiful. Thank you for sharing that. And I love the value difference of the black and white, because that's such an important distinction that I think that could get overlooked. Now, do you take photos on every single patient that you care for?
Every single aesthetic case. Because one of the things I talked about in Florida was, I think all of us, everybody wants to be a better doctor tomorrow than they are today. And the only way you can do that is you need to look at your own work. And when I was younger, I used to look at it all the time as, oh, geez, what did I do wrong? What did I do wrong? Now I'm a little more mature. I look at it like, okay, not bad. What could I have done better? So I blow things up, and there's a monitor next to me here that's like the full size of the wall. And I put it up there and I look at it, I'm like, okay, I did this pretty well. I did this pretty well. This could have been a little better. I think that's a good way, at least in the dental profession, to go through things to help yourself. One, feel good about the things you did well. And then two, look at, yeah, maybe there's some things we could have done a little better.
That's awesome. Well, congratulations on being published with this paper. We will have it. We'll have it linked on the Rarebird site if you guys want to check it out and read the full article. Rarebirdspeakers.com. Thank you for that. So then, with that, are you mainly the aesthetic dentist in town, or do you do everyday dentistry as well?
Oh, we do everyday dentistry. Yeah. Well, it's interesting because before, like 2007, 2008, the big real estate crash, I had a lot of doctors sending me cases. And then when patient money got tight, everybody kind of rolled their stuff in. And then the docs who were sending me stuff kind of decided, well, I'm going to give it a try myself. Even if it doesn't work, it's practice income, right? So we do things for other docs here for sure. And they're mostly composite. And I have an agreement, an actual sheet that I send them that says, here's what we're going to do for you. We're only doing this one thing. So if they sent like that young lady, patient like that to me, I would do that. And then the patient goes back. Because otherwise, what they're worried about is patient's going to stay. And we do have people that come in here and they love my staff and they like the environment and they ask to stay, but we tell them before we start, I'm like, I'm sorry, we're going to do a fabulous job for you, but you can't stay here. When you're done, you got to go back. That's just the agreement. And to me, honor and integrity is everything. And if I gave my word that the patient's not staying, then they're not staying.
Yeah,
So
and then also too, I was thinking from that with a liability standpoint too, because you could be referred for 1 or 2 teeth and they have 6 other carious lesions that are there, and then they never come to see you
right.
again. So it could be abandonment as well,
Yeah.
depending on who
And
your owner-patient-provider relationship is.
we have those challenges where people come in and they want aesthetics. Everybody's all about Instagram and their veneers and all that. And I want 10 veneers, and they come and sit down and they got a whole myriad of other much more serious problems. And now that I'm a little wiser, a little more confident, I just tell them, hey, I show them everything that's going on. We would love to do this for you, but this takes precedent. No, it doesn't. I would just want my veneers. I'm like, okay, I understand, but I'm sorry, I can't help you. I just can't. And there's 20 other docs within spitting distance of a hero gladly do that, and good for them. But I think, we are supposed to be health practitioners, so that doesn't just mean teeth practitioners.
Yeah, that's good. I mean, you gotta stay true to your ethical core values
Yep.
or what you stand for. Um, well, thank you for sharing that with me. And if you all have any questions about the cases or how he does anything, please feel free. The link to his contact information is in the show notes. And just any final words, Dr. Morgan, on or advice on these types of cases that you would like to give?
Sure. I think, like I said, I understand somewhat the pressures and stresses are a little different on the younger practitioners than some of us guys and girls who've been around for a while. But composite does take a certain amount of dedication, and it's not something you just take like a weekend course or read an article and do well. And there are lots of people you can go learn from, and you don't have to crisscross the globe like I did. There are plenty of people in whatever country you're in, whatever area you're in, that can help you with that. But it can be really, really fun. I think one of the biggest challenges for us practitioners, and ask me how I know, is you start out the fees so low. Your fees so low because, especially if you're taking like PPO or something, and they're going to give you $137 for something that takes you 2 hours. That just doesn't work. It doesn't work.
Right.
So when patients come in and they have certain insurances, and they call on the insurance, says, yeah, we're going to give Dr. Morgan $137 for doing this complicated class 4. I just tell them, I'm sorry, we can't. This has got to be cash only outside of insurance, because this kind of work, you can't, in the normal world, you can't go somewhere and want a Lamborghini, but then you want to pay for like the Kia. They're both great. They both get you places, but one's definitely different from an aesthetic standpoint. So it takes, for these young folks, it takes some time to learn. And I realize 3D is going to eat up a lot of that because they don't have to learn. They can have somebody else design it, somebody else print it, they can cement it in. Okay. That I would rather they did that than did a really not good composite. And then the second thing is there's a group of, all the Facebook online groups and everything. Those are always super intriguing. And there's I'll call it a small group online, because there's great guys like Art Volker, awesome guy, super talented, helps people out, shares like, you wouldn't believe, just wonderful. There are a lot of docs like that in our profession, but there are a few that aren't good at composite. And instead of just saying, yeah, I'm not really good at composite, they call it composite shit. It's not, instead of composite. And I've tried having one discussion with one of these guys, and it's a total waste of time. So if you don't know how to use something, then just say, hey, I'm not very good, or I don't like it. It's okay if you don't like it.
Right. It's just not your thing, not your jam.
But in my hands, it works pretty good. And then there's people, DHA, Vanini, Fall, people like that, just like crazy talented with this. So if the material was shit, it wouldn't work in their hands either. So don't blame the material. Just say, go get some training, go get some training, because porcelain's not that difficult. The lab guy's going to do it all for you.
Yeah. But to your original point, if you're adding instead of subtracting, there's always more that you can do later. So staying with that minimally invasive first and
Yeah.
attempting to do the best that way. But it takes time and dedication to your field. So, well, thank you for your words of advice and for sharing your cases. It's amazing stuff.
Well, thanks for having me on, Kelly. I very much appreciate it.
And again, if you guys have any questions for Dr. Morgan, his link is in the show notes. Thank you so much for listening. Continue to listen to the Dental Handoff. I always ask the favor to go onto Apple Podcasts to give a Dental Handoff a 5-star rating, please. 555. And if you're watching this on YouTube, go ahead, like, subscribe, and share to your friends. And then put a little comment in the section so the algorithm knows that you love us. Thanks for everything that you do. And we will see you again next week, my friends. Thanks, Michael.
Gracias.